No, I think one of the huge things, the differences is between primary and secondary care. I guess I get the bias of seeing the people with the disease, and in those patients, the benefits of treatment are much more larger and clear cut, as you indicated. So, and one of the frustrations I sort of have is that the sort of skepticism and the reluctance to use medications. It's quite reasonable, and the balanced decisions in primary prevention seem to often get translated to secondary prevention, where people actually have the disease and the absolute benefits of the medication are so much more clearly established and definite. And we know that for various reasons half the medications are stopped within a year after a person's had a heart attack. So in the broad sense, I think a lot of the question marks around the benefits of treatment go away once you've actually got the disease and you're clearly now 10 times higher the risk than you were before you've had the event. And that I think so not all these discussions about pros and cons of medication differ a little bit in that situation. And then the other thing I often get faced with as a specialist, is should I take the prevention? My family's got, all my members of my extended family have got coronary disease. Am I going to suddenly have I got it? Am I going to die? Or my best mate's just had a heart attack. Now I'm worried that I'm going to as well. And so obviously and my slight issue is that the risk equations are actually relatively crude. So trying to, so the C statistics show the probability that you have an event as against you don't, based on your blood pressure and diabetes and the things that determine the risk, are only modestly accurate. So the question is, do you look for actual evidence of the underlying disease? And that's a whole different question. But once you've got the disease, so if, for example, one way we can do it is a very high CT calcium score. I'm not saying that should be done, but if you do have evidence of disease, then that marks you out as being at higher risk than if you don't. So, and there's obviously a discussion about how that would be. So I think one of the things about medication is what's your risk. So that's what you're saying is you should target the patients at the highest risk, and that's driven, well, conventionally done by risk factors, but there are potentially other ways you can say, well, are you at higher risk? Have you got evidence of including, specifically, have you had an event? Then you're definitely at risk. Or have you got other clinical evidence of the disease? Then you probably are at risk, at higher risk than you otherwise might think.
I think the interesting thing with the risk tables, if you take the 15% threshold, most heart attacks actually occur with people at lower risk. It's a bit like the Down syndrome thing. Most babies are born to women below age 35, but your risk is higher over 35. So I like to think of the risk tables as a pretty good rule in. You need to do something, but you can't be sure that they're a good rule out. And so perhaps along your lines be a little bit more, and most New Zealand GPs and nurses aren't following the 15% risk. We tend to treat actually to individual levels.
But the other point you make is that there's a big individual difference in what people are willing to do. So there's a big difference between somebody saying, well, all my brothers have died. You say that because it's only, that we know actually genetically determined risk actually increase your risk by maybe only 20%. It's not like 20 times, which is what people think. It's only a modest increase because a lot of it is explained by the conventional risk factors. But nevertheless, they are motivated to do something to reduce their risk. So why would you say, I wouldn't go, I only 12% risk, don't go away. That's completely different from somebody's having no particular interest in taking medications, and then you're trying to persuade them to. So I actually think that where the patient's coming from actually matters quite a lot, and they're the ones who have to take the medication. And as you said, Bruce, everybody benefits. It's just a question of quantifying how much and whether it's worth it. But if you're perfectly happy to take the medications and you want to do everything you can, then my view is, well, there may not be a huge magnitude of risk in the short term, but it's a reasonable, maybe a reasonable thing to do.
If you have a case, we'll be happy to do it. So I've got it's therapeutics collaboration. It's it's Therapeutics Collaboration. You get a different website, and then it's the CVD calculator. I will do that. It's quite nice because it tells you what you might want to treat first versus second, which is quite interesting. People often say to me, "What do you treat first?" 60-year-old Pākehā male, smokes 10 per day, blood pressure 160/90, no family history of CVD, not exercising, BMI 29. Actually, if you think of the 170 over 100, he actually doesn't meet the criteria from the New Zealand guidelines, but I don't think any of us would leave this guy alone. This guy's, while he's smoking, he's actually causing himself. So just maybe in pairs, just talk about what you might do with him from a non-drug point of view, and then what you might want to do in terms of drugs. So that's his lipid. So he's got a pretty typical, the average total cholesterol in New Zealand is 5.8, very high if you're Japanese, but Japanese are about 3.8. That'll have hypercholesterolemia if they came to New Zealand. So, so that's HDL. So not diabetic, normal renal function. Okay, folks. So what do you want to do with this guy? Who's got some suggestions? Sorry?
Smoking cessation.
Yeah. It seems a bit pathetic to give him drugs if he's to lower his cardiovascular risk
But what if he says, says or does, just not going to do that? Does that mean you change your mind on the other things?
I guess you do.
Yeah.
No, you're saying you don't give him medication because he's going to keep smoking.
No, I was just saying it always seems a bit tragic to treat a guy like that because
of his
risk. Oh yeah, no, get him off the cigarettes as soon as possible.
No, but I mean what I'm saying is that some people will do and some people don't. The fact that he shouldn't mean that you say, well, we're not going to do anything else for you, because he actually is still carrying the high risk, and you've got to a certain extent. I mean, it's a classic example here of, don't you have to sort of somehow negotiate, you do what you can? I mean, ideally you could say, well, he needs to be on a Mediterranean diet, he needs to exercise regularly, he needs to lose a couple of kilograms, he needs to stop smoking, and he needs to take a statin, blood pressure medication. That's what I'd do if I was try to do if I was him. But whether I'd achieve all those things, and certainly whether he'd achieve all those things at the first visit,
and whether he would remember that as he walked out.
Yeah, and said, "Oh, stuff that! I'm not going there again."
I go to physiotherapists and they tell me 10 things to do. I've forgotten eight of them by the time I get to the door. I get to the car, I've forgotten the 9th, and on the way home I forget the 10th. So they have to email me the stuff if they want me to remember anything.
So in this case, I mean, how do you? I mean, I'm interested from your point of view. How do you? It's basically some sort of negotiation, I imagine, and it may not. You can't necessarily achieve everything in one go. Yes, do you have to sort of?
Yeah. I mean, getting some lifestyle thing, I think.
Did you get him to the dairy to get a cigarette?
Well, I really like smoking cessation. I think it's fun. I have this little thing I say to people: you're 60 years old. That's a good age to quit. Whatever the age, 61. That's a good age to quit. And they look at me. I think it gets into their subconscious, and I would say to this guy, this is tiger country. I literally say that. They're my exact words. This is tiger country. This is when the strokes and heart attacks are going to happen. When they're 50, I say, if you stop now, you won't get the lung problems. We don't see many people short of breath at 60 who aren't smokers, but by the time you're 60, you're going to have trouble walking across the car park to get here. And I always try and find a big reason.
So it's interesting that you try to, as much as possible, actually exaggerate the risk. Is, I mean, that, you say you won't, if you're keeping smoking, you won't be able to walk across the car park. In fact, you probably still will be able to walk across the car park.
That's right. Yeah. No, I think stretching the truth is totally appropriate.
It's probably absolutely. Yeah.
Well, I've seen too many of these guys, have lung cancer or strokes and heart attack. I mean, I've been around.
And actually, I just wonder if that image. If you give him a smiley face, he's going to say, "Oh, bloody." But if you say, "I won't be able to walk across the car park," that will be something he might keep him awake at night.
Absolutely, yeah. You see the guy, it's going to be you. Yeah. So the other thing is people need a big reason to quit, and I always try and find out what that reason is, and then play off that. So, like, why do you want to quit? Well, sometimes it just comes down to saving money. But when I show you my little thing about focus, acceptance, and commitment therapy, I will talk about how I got a guy to start with an HbA1c of 149, got him to take his short-acting insulin in 3 minutes. Yeah, so you're getting him to stop smoking if you can. And remember, most people will actually quit smoking without any help from health professionals. About 90% of people quit without any help from us, which is a bit disappointing. But I think you've got the person in front of you, and in our clinic we ask every smoker about their smoking at every visit. Very few people get irritated by that, and I think if you don't have that policy, you're not asking anybody ever. That's the risk. If it's not everybody, and we just say to them, in fact I discovered this one day with a 22-year-old woman in the office. She said, every time I come here someone asks me about smoking. I said, every time? Has there ever been a time when you came here and nobody didn't? She said, no. I said, that's fantastic. That's absolutely fantastic.
There is a downside though. I had a patient who rang me up and said, they said I was a smoker on the discharge summary and had smoking cessation advice, and I haven't smoked them for a year. And obviously it was some sort of tick box thing.
Yeah.
And he was going to get the lawyer onto it because it wasn't correct.
The one in every crowd, I think, Rafe. Okay, so what else might you want to get this guy to do? So he's drinking 3 to 4 beers a day. Is that? He says all my mates do it. I go down to the Cossie Club. What might you say to him in that situation?
Reduce alcohol.
Mates are going to try beer too.
Well, actually, from the just from the narrow blinkered view of cardiovascular disease, that's not a problem.
No, more problem for his blood pressure if he wants to get his blood pressure down. So, I would leverage off that to get him to sort of cut down to maybe 2 a day, 2 or 3 a day. You know, I think people make a mistake when they stop.
I guess it's the weight as well, isn't it? Though it's a great source of calories.
Sorry?
Three jugs of beer is a good source of calories.
So how easy is to get this guy to lose 5 kilograms of weight? Who's managed to get 5 kilograms off this average New Zealand man and keep it off for 10 years? Raise your hand. Pretty hard, isn't it? This happens to me. The poor old medical students say, I ask the patient to exercise and lose weight, and then I have to sort of explain to them actually.
Yeah, I actually wonder, should we actually not beat people up on weight so much? Because given that we know that how hard it actually is, and it's usually, I mean, shouldn't we go for the things that we know are more likely to be successful?
Well, certainly I don't find it. Smoking cessation is a piece of cake by comparison. You know, I think smoking cessation is relatively easy. I have pretty good success with smoking cessation, getting at people and just our clinic and patients respect you for doing it because you're a health professional. That's what you damn well should be doing, you know. And they get that. They don't think you know. There's the odd person who sort of rolls their eyes and groans, but that's a minority. Could I ask people, what do you think of us asking everyone? Well, okay, you know, you're a doctor, or nurse, or you should be asking that. So. So your question about no personal history, family history. So in the New Zealand context, you add 5% to their 5-year risk, but that's a broad approximation. So that's not based on science, but as Rafe says, it's very variable, and it's not. You are at increased risk with a family history. Okay, so what? Okay, let's have a look at this. So we can just have a wee. So this is where this thing's quite fun. So I'll put in his risk, and his risk is quite high over the next 10 years. So that's his risk over 10 years. So 37% of people are going to have an event in the next 10 years. So this guy is an MI equivalent, really, even though he's never had an MI. Let's try physical activity in here. So physical activity is pretty good, but still. Let's try Mediterranean diet, even better. I don't know how you're going to get your average Kiwi male on a Mediterranean diet, but
well, actually, the interesting thing about a Mediterranean diet is it's actually mainly, it's not necessarily what we think of as a traditional Greek or Italian diet. It's just lots of fruit and vegetables and less processed foods, essentially, what it comes
unsaturated fats.
And getting the saturated fat, or the meats and the saturated fats,
So low to moderate intensity statins. So this is a atorvastatin 20 and below. So reasonable bang for your buck. So hypertension gets quite a lot for this guy. So it gets 10, 11, 12, 13, 14 out of 14% absolute risk. You see, I think if somebody says, well, should I be on medication? I don't think you can say, can you do better than that? I don't think you can. I think this is perfect. As I say, most of my patients have.
But it's not one or the other. Why would you just do a blood pressure put the statin on as well?
Oh, you can't do two at once.
You can't do two at once.
No.
See, if you're going to take a pill, why don't you take 2 pills?
Yep.
I mean, it's not that big a deal, really. As long as the pill doesn't cause any harm.
Yep.
And then you'll get even more smiley faces.
Yeah. Well, this is so. Normally in practice, I would start with one medication. I wouldn't start with two because.
Right. No, fair enough. But yeah, that might be the strategy.
It doesn't do two. So niacin doesn't work. And really, I guess when it comes to statins, it's either statins or ezetimibe. Really, nothing else.
What does it do when you do ezetimibe? Because that's a bit controversial.
Yeah, that doesn't
work according to that.
NNT of 50 to prevent. They're sort of out completely now.
So for somebody who can't take statins anymore, are they still going to do anything?
Exercise is as good as statins, interestingly, if they'll do it. Or we've got a case of that actually. What to do with somebody? There are a few options there. Let's add ASA, so aspirin's pretty not big. But remember, this guy's got a very high risk because of his smoking. Let's take his smoking off. Sorry, this is just going to... There you go. Yeah.
He's resisting.
He's having trouble. And it's not my... Okay, so there we are. What are we treating? We're treating... That's aspirin. That's lowering his blood pressure. That's adding a low to moderate intensity statin. So if you're going to give pills, then... people often ask what you should start with. I do tend to start with getting the blood pressure down, because I sort of think that's probably it. But I mean, there's no trial evidence as which to start first.
Do the alpha blockers have any place?
No. It's statistically inferior to chlorthalidone in the ALLHAT trial.
So if you've got someone that's on alpha blocker for a prostate,
yeah,
and it's blood pressure, you're not doing anything good at all to his cardiovascular risk?
There's no trial evidence, basically. And have you heard of the floppy iris syndrome? So you get my gems, you know about the floppy iris syndrome. Do you know about the floppy iris syndrome?
Yes, intraoperative floppy iris syndrome in patients with undergoing cataract surgery.
Yeah. So they've been on alpha blocker. So the surgeon and anaesthetist need to know, because they do a different procedure. Otherwise, you blow the eye, basically. So it's a bit scary. Are you going to remember at 75 taking an alpha blocker for your kidney stone at 25? It's a bit worrying. So I suspect they take a very thorough history around that. You know, have you had kidney stones? Because most people aren't going to remember. Yeah, so even a single dose may cause floppy iris syndrome. Yeah, so no trial evidence. I mean, alpha blockers were supposed to be the wonderful thing, lower your blood pressure, improve your lipids. Hasn't turned out to be. There aren't a lot of trials, but in the ALLHAT trial, they stopped that arm because chlorthalidone was so much better.